All right, good morning, everybody, and thank you all for being here. My name is Michael Juntanen. I am the incoming president for the Minnesota Ambulance Association. Before we start today, I'd like to take just a minute to express our love, support, and sympathy to the families, loved ones, and everybody who was impacted by last Sunday's incident in Burnsville. The loss of those three heroes, the two police officers and the paramedic who was rendering aid, was devastating and weighs on us all. All right, so thank you for the reason that we gathered here today, kind of a call to action for the Minnesota EMS crisis. Minnesota's emergency medical services, the very lifeline of our communities, is in crisis. From rural towns to urban centers, the system is currently strained, underfunded, and at the brink of collapse. This isn't hyperbole, this is reality. This crisis demands immediate attention and decisive action. The two issues that really we're facing today revolve around workforce and funding. On workforce, we have people who are dedicated EMTs and paramedics who are leaving the field in droves. The most recent numbers from the EMSRB in 2021 showed that there was nearly 3,000 more providers in Minnesota who left the industry that year than came into it. Most of those leaving were under the age of 40. This shortage can mean longer response times, especially in rural areas where ambulances are stretched thin, leaving lives hanging in the balance. Second, we talk about funding. Arguably, one of the main root causes of the issues that we're facing revolves around the reimbursement rates from insurance companies, specifically the governmental payers. The reimbursements that we're receiving do not cover the true cost of care. This financially cripples EMS providers, forcing them to have to choose between serving their communities and keeping their doors open. These aren't abstract issues, they have real human consequences. If we get to the point where we're starting to see ambulances were taking an hour to respond to a call, a patient who's experiencing a heart attack, they can start to see their chances of survival plummet. If a rural ambulance service can't get an EMT to staff their ambulance for the day, a simple fall can become a tragedy. We cannot and will not accept these risks to our communities. So today is a call to action. We ask our legislators, we urge you to invest in our EMS system, ensure fair reimbursement rates, and create pathways for recruitment and retention. To our local communities, we ask you to raise your voice, demand change, and support your local EMS systems. And to my fellow first responders, we stand with you, and your commitment to what we are doing today is more essential than ever. Minnesota's spirit of resilience is strong. Together, we can overcome this crisis and ensure that everyone, regardless of zip code or income, receives the emergency services that they deserve. Let's work together to build a stronger, more equitable EMS system for everyone in Minnesota. Thank you, and I'll now turn it over to Senator Grant Hauschild, who is the Senate author for one of the funding bills for EMS.
Well, thanks everybody for being here. Like you said, I'm Grant Hauschild, and I'm the state senator from District 3. District 3 is the largest and most rural district in Minnesota. It's all of the North Shore, half of the Iron Range, half of the Canadian border. So I represent some of the most isolated communities in Minnesota. And that gives me a unique lens as we look at, frankly, all issues, but in particular, the issue that has risen to the top is this EMS issue that we're facing. Over the last year, I've held several roundtables throughout the Iron Range and in northern Minnesota to talk to ambulance directors, mayors, and stakeholders about this issue. Through those conversations, it became clear to me that this issue is acute in our rural communities. That is why I joined my colleagues, Representative Lislegard, Representative Brand, and others to call for an EMS task force that would really dive in on this issue, do roundtables all across the state beyond just northern Minnesota to find out what the core issues are that we face. What I took away from those conversations, both in northern Minnesota and across Minnesota, from urban to rural, is that we're not just facing a problem or a challenge like we talk about often in policy. We are facing a crisis. I cannot emphasize enough that this is a crisis we are facing in Minnesota. After calling for the task force, we visited all of these different communities, and what I want to emphasize in particular for the rural communities is that this is really a double whammy on our communities and on our citizens. The issue is that oftentimes in the more urban areas, you might have a private hospital provider, a large nonprofit that can provide these services. However, when you reach the more rural areas and the isolated areas, it often falls on our local communities as a last resort to take on those licenses to manage those services. So you think about this. Not only are these rural communities not getting the private support that many of the other areas of Minnesota have, but they're also expected to pay for the service through their property taxes with an area that already has some of the lowest property tax in the entire state. Representative Lislegard behind me and I, the co-author in the House, represent Aurora and Hoyt Lakes, a twin community on the Iron Range, which was named the poorest community per capita in Minnesota. They run the EMS. The poorest community per capita runs the EMS for that community and surrounding region. That is why this is such an acute issue for greater Minnesota. So think about this. They're doing everything they can. I have ambulance directors, volunteers that are doing this work, not getting paid. They have opportunities to work in small businesses and fast food to get paid more than they do through the volunteer EMS that they're doing. And we're already shrinking in population. If you expect people to live in rural communities, they need to know that their zip code won't determine whether or not an ambulance shows up for themselves or a loved one. This is an equity issue. It is a rural-urban divide issue, and we need every single legislator to understand how important this issue is. So it's my hope that over the coming months, this session, that this issue will rise for everybody to the crisis that it is that I see in my region. And with that, I would love to call up Representative Lislegard to talk a little bit more about the bill that we're proposing to provide emergency funding for this critical issue.
Thank you. Well, like Grant said, I'm Dave Lislegard. I represent 7B up on the Iron Range, and Grant kind of laid everything out. But I'm very honored, and I learned so much traveling the state on this task force. And one thing that I'll just say that this is not Democrat or Republican. This is a statewide issue, and it is our job to put the people of Minnesota before politics. And that's what I'm committed to doing. That's my colleagues behind are committed to doing, and that's what we're going to do. So thank you.
Hello, my name is Becca Hipsch. I'm the ambulance director for Perham Area EMS, and I serve on the Ottertail County EMS Task Force. Before going any further, I would like to express my deep sympathy for the events that took place in Burnsville and offer support and condolences to the EMS community and the family of those that were lost. I'm here because the current financial situation faced by many rural EMS organizations threatens the entire emergency medical safety net. Perham Area EMS, along with other rural ambulance services, has experienced year-over-year losses due to the increasing cost of medical supplies, labor, equipment, vehicles, and which has greatly outpaced the reimbursement from federal payers, state payers, and commercial insurance. This comes at a time when we have an aging and medically needy population and are seeing increasing requests for ambulance services year over year. Ambulances are no longer able to cope, and I fear that without the support of the state, the network of ambulance responders around the state will collapse. Ottertail County's 7 EMS agencies collectively experienced a $1.5 million loss in 2022, a number that we expect to increase for 2023. We see more and more calls that are not reimbursable because they do not require transportation to an emergency department. Our losses translate to an average loss of $182 per call. Our volunteers, furthermore, 4 of the ambulances in Ottertail County rely on volunteer labor, which frequently only pays about $1.50 per hour for readiness. These volunteer staffed ambulances are experiencing higher than ever call volumes, longer transport times, and a decreasing pool of trained staff to respond to calls. When we did the math for our county, if this volunteer subsidy were to disappear or become unsustainable in the future, it would cost about $1.4 million to replace their labor with trained staff. We've exhausted every avenue before seeking support. Efforts to reduce expenses and optimize reimbursement have proven insufficient. Labor costs constituting about 75% of our expenses leaves little room for further cuts without losing availability or service level. Deferment of our capital purchases means that there are large looming expenses in our future and that our equipment and vehicles are aging. Our rural setting means that longer transport distances and greater geographic areas requiring coverage results in fewer transports per vehicle and lowers opportunity for revenue. We can't quantify the hands held, kind words spoken, sleepless back-to-back shifts, or countless instances where our teams went above and beyond. Ottertail County ambulances responded to over 1,700 calls in 2022 where no reimbursement was available. These calls were lift assists of elderly. They were motor vehicle accidents where the patients refused transfer. They were treatment and assessment in people's homes. Or they were simply when someone called 911 and requested help and we showed up to be there for them. All of these services and others, despite being of great value to the communities in Minnesota, are at risk of being lost. I strongly support the proposed funding for EMS sustainability and innovation. If we can achieve this together, we will never have to wonder if an ambulance will show up when we call 911. Thank you for your time and consideration.
I'm gonna go. So sorry I'm late. SRO is just passed in the Public Safety Committee. It's a big vote, so we're glad that went on the way. And this definitely is not an officials meeting. I've been in official conversation, sports officials all week. As you know, we've been conducting a task force around the state that was appointed by House and Senate leadership over the summer. And that task force, basically, you heard the testimony here today of our heroes. And it's scary out there that what they're asking for is really a drop in the bucket. That scares me because how did we get here? What led us to this part? Is it the feds? Yes. Is it the state? Yes. It's a little bit of everybody. And it's time to buck up and let's figure out how we're gonna fix this. It's not gonna be fixed by one silver bullet. It's gonna have to be everybody. We're all gonna have to dig in and work together. It's gonna take change. Unfortunately, for years, volunteers in our outstate have subsidized EMS. They're subsidizing fire. And that's not the model that's going to be sustained continuously. We gotta look for a different model that works for all. What I believe the state's duty is when someone calls 911, we send a helper. And these people behind me are helpers. So we have to figure out how we're gonna get them there quick, prompt, and make sure we're doing what's best for the patient. Were there another speaker up here that you wanted, or? Mayor.
Thank you, all of you, all the EMS people that are here today, our task force, the representatives that represent my district. This is not a woe is me issue. This is a critical issue. And I'm going to give you a story, my story, and it's the story of our city and the story of many rural ambulance services and EMS systems that are really suffering moving forward. So like many other communities in the rural area, we are experiencing many challenges in an attempt to deliver quality EMS services. We are challenged financially, we're challenged by equipment, we're challenged in the areas of being able to provide the services that are necessary in this regard. And I'm going to use City of Virginia as an example. I'm mayor of the City of Virginia, Minnesota, and we have a full-time ALS service. We run 6 ambulances. We have 38 full-time ALS services. We have full-time firefighter paramedics. We have full-time paramedics. We have full-time EMTs. We operate a PSA area of 640 square miles. The average ambulance run is about 200 miles from patient to hospital. We have one hospital that we use most of the time in the critical hospital, and that's Essential Health in Virginia, Minnesota. And so when we respond, that's how long it takes for us to get there. In 2023, the City of Virginia had 2,664 EMS runs. That does not include transfers, and that does not include intercepts. 1,253 additional ones were transfers, whether they were intercepts or regular transfer calls. 1,667 of those were Medicare runs with growth charges of $3.7 million, and we only collected $1.03 million. So in 2023, and this has been going on for the last 7 years and beyond, but since my tenure here, in 2023, our ambulance service lost $552,723.24. And where does that money come from? Not the other communities. It comes from the city budget. And the city doesn't have that money in the budget, so we've been covering the costs for our ALS service with our reserves, our cash reserves, and our investments. Well, we can it's not sustainable. In 3 years, we're not going to have any money in our accounts to pay for that. We've committed to the ALS service. The citizens of Virginia have committed, and we want to continue to provide that ALS service for those who do not have that service in our rural area. The first responders, the EMTs, the volunteer firefighters, the volunteer who run the ambulance services, they rely on us to help. When a call goes out and they can't respond because they have a work commitment or something's going on, we automatically respond when the call comes out in case they can't, so we can get there as quickly as possible to help provide critical care. So please try to imagine the challenges that all of you have that are sitting in this audience, and all these people that are sitting behind me, the ALS services. What are the challenges that they have? The challenges are what? Staffing and funding. And sadly, EMS is not considered an essential service in the state of Minnesota, so many of the mechanisms by the state that supports essential services are not currently available to the EMS systems. The City of Virginia bears the entire cost of the entire service area of 640 square miles. When a volunteer or paid on call are unable to respond, we do that. So Minnesota statute, section 144F.01, gives an ambulance district the authority. The statute gives us the authority to levy a tax to the service that we provide. But the caveat is that each individual committee has to sign on by resolution and approve and give the authority to the provider, in our case ALS service, the ability to collect money enough so we could make our break even. That's all we're asking to do, is to break even. That has been a huge obstacle, a huge challenge, because these small communities can't afford to pay any more taxes. Number one, they can't even afford to help subsidize their own ambulance service, which are BLS, basic life support. So we need a new sustainable model, a source of revenue to alleviate this burden. This data highlighted in 2002 Minnesota Department of Health report in 2002 titled "A Quiet Crisis, Minnesota Rural Ambulance Service at Risk," which outlines a plan to address EMS statewide. It's very comprehensive, but nothing was ever done. And that's why this EMS task force is formed, to help look at this, to find new methods and new ability to help all EMS systems be operable so that we can break even, so we can continue to provide emergency services. It's not a quiet crisis anymore. It is an immediate crisis, an immediate crisis. We need immediate short-term help, intermediate help, and long-term help to make this a sustainable model for many years to come, whether you're in the metro area or you're in rural Minnesota. I'm speaking only in the rural environment because I don't know the EMS systems in the metro. I can only imagine the challenges they have as well. But we are very grateful and encouraged by the development of the statewide EMS task force, who has taken on the daunting and complicated task of recommending sweeping changes in the EMS in our state. And it's long overdue, long time coming, and we applaud them for the work they're going to do. And we urge the task force to use the comprehensive 2002 Minnesota Department of Health Plan as a reference guide as their work continues to the end of the year. We unilaterally support, all of us, Senate House File 3886 and House File 3992, which is the emergency ambulance aid, in which allocating, at least for the 2025 allocation of $120 million. As the chief of the fire chief of the Hibbing, Minnesota says, who also runs a part of another ALS service, says, it's a start. It plugs a hole, but it doesn't stop the leak. And we need that moving forward. So we as EMS providers are ready to support and lobby for real change that will help us provide a viable and life-saving service to our respective communities. Our lobby is strong. We hope that we will support it. We are unified and committed to this goal and objective, and we are confident that the EMS will be one of the highest priorities in the 2024 legislative session. So thank you for the opportunity to speak today.
Thank you, Mayor. Good morning. I'm Dr. Nick Simpson. I'm an emergency medicine physician and EMS medical director at Hennepin Healthcare. As others have shared, EMS is at a crisis point in Minnesota. And I want to share that this is an issue that affects all Minnesotans, regardless of zip code. No one plans to have a medical emergency, and EMS is a critical healthcare safety net for our state. When you look at the ems.gov website and you click the link that says, "What is EMS?" you'll be directed to an image showing that EMS is at the confluence of healthcare, public safety, public health, and emergency management. Despite EMS working across many disciplines, it's not something that many people think of until they or a loved one have an emergency. And as I stated, we are lucky in Minnesota that when someone calls 911 and requests help, they get an EMS response in the provision of care. This happens without regard to things like health history, spoken language, age, gender identity, or insurance status. At the height of the COVID pandemic, we saw many challenges. We saw many retirements from EMS. We saw career changes. Our EMT and paramedic schools were unable to operate due to the restrictions. We're also adapting to a changing demographic of our state and population. Despite these strains, we want to continue to serve. Minnesota has been at the forefront of many innovations and advancements in EMS care over the years. We were some of the first to provide pre-hospital STEMI activations for heart attacks. We've been leaders in cardiac arrest survival. We've been leaders in the nation with our community paramedics. We have some of the best trauma outcomes in the country. We have a coordinated system of stroke care. And we led the nation in equitable allocation of resources for some of our most precious and specialized resources during the COVID pandemic. We sincerely appreciate you all thinking about us and talking about us now with this important issue. To our legislators, I would urge you to talk to those elected officials who have been out on a ride-along, and to those who have been, I would ask that you please continue to share that experience. EMS is made up of people that want to continue to serve. So help us keep the doors open today so we can continue to innovate and move forward. And at this time, we'd be happy to take some questions.
How would the funding be used that you're asking for the state? Would it be to recruit and retain workers? How would it be spent?
Great question, because what we're seeing is where the lack of funding is pretty much we're looking at a shortcoming in equipment purchases, helping pay for education. Right now, it's about $1,600 to send this is an entry level, send an EMT to school. So many of these things can help the volunteer services elevate that. Simply, I have a request right now on my desk back at the office that is asking for help with gas, with tires. It's pretty bad out there, and so there's a number of needs. It would have to be an open grant. Definitely accountability would be put in there, but these are, one of the saddest things a reporter recently asked me was, how are volunteer services failing? It's failing because we don't even have enough to get the gas to get out the garage right now because of the reimbursement scale and things like that.
Is there any effort, though, to make those cities like Virginia whole, who have been using their reserves and things like that?
If I could just go to Tom's question first and so forth. I'm Representative Jeff Backer. I've served as a volunteer EMT for 29 years. I'll give you a good example, Tom. Our service, the Browns Valley Ambulance, every year we have to do a pancake feed and a fundraiser letter to raise over $30,000 so we can get the rigs out of the garage. So we're talking about essential services. When someone dials 911 way out on the western part of Minnesota, they want service. And this is the funding that we're talking about. Last week, when I was down at the Capitol, my identical twin brother was out of it. We had 5 12-hour shifts. If somebody dialed 911, we had to work with the neighboring ambulance. So like what John has talked about, we're talking about the basics. We're not talking about any high society stuff. We're talking about just when people, we want to make sure that they get the care and so forth. So thanks, John.
Is the crisis both in the paid force and the volunteers? Because obviously there
Is
are
a
some
deficit
paid-
there?
Yeah.
Yeah, we're hearing it on both sides, because if you have a high volume area, I remember talking to my boss once when I worked in EMS, and they said, oh, well, we'll lose money on each run, but we'll make it up in volume. Doesn't work. They're really, they gotta stay competitive. Medics have to live, EMTs have to live, we have to pay decent wages to keep them there. And unfortunately, we saw an incident this weekend. These people are out there giving their lives, and we need to make sure that their livelihoods are protected, and that's where we're sitting as managers, all the way down from volunteer all the way up, are having trouble with the reimbursement. So yes, it's a good subject. The Fed's money that's coming to us is not working anymore. We have to come up with a new option.
So,
Yeah.
yeah, my question was about is there an interest in also funding those cities that have been draining the reserves, like Virginia, and making them whole?
So, yeah, I'm sorry. Yes, we need to look at it, and I gotta be honest with you, from our speaker in the House to the leaders in the Senate, both sides of the aisle, to the governor's office, we're all looking at how this can iron out, can make them whole. We have to look at that. Remember, we also just recently, last year, both houses and the governor passed a $300 million public safety grant. That could have been used in these areas. We're finding that very little did. And so that's kind of what we're looking at is, well, where was that used and why wasn't it used here if you're having trouble? But no, we are looking at trying to make these cities whole and to get them to where it is. And I know many of our ambulance services are private in the state, so that brings in a different relationship. But I do want to clarify this. I heard it in committee yesterday. None of our ambulance services in the state of Minnesota are equity owned. That means that Wall Street is not even close to Minnesota like it is in other states. And that is a blessing upon us because we really are, what the doctor said there, this is about doing the best job we can. We're not answering to Wall Street. Thank you, though.
But this is one-time money. It's an emergency cash infusion. I know in that,
Right.
the task force, though, last week you talked about, you have to come up with a long-term solution to this.
Yep, and every one of there's a number of task force members here today, the Senate and the House. We are looking for long-term. We know that if we're gonna wait for Washington, and I don't wanna throw our legislators in Washington under the desk because they've come to us. Tina Smith is a rock star on this right now in Washington, but that takes time, right? We can't wait anymore. We gotta I don't wanna say whole, but we have to do something here in Minnesota. So when you call 911, you're gonna get an ambulance, whether it's up in Virginia or on Lake Vermilion or in Apple Valley where I live.
What is it that prevents you from charging or being reimbursed for non-transports, for treating people at home Is that something that the state has the power to change, or is that a federal Medicaid, Medicare thing?
Right, John, that's a great question, and that's what we're digging into right now, is that we know that our ERs, and the doctor probably can vouch for this, that our ERs are boarding patients right now. And if EMS could cut that down, this is so ridiculous. The only way you can bill a patient is the patient has to be in your ambulance and the wheels have to roll. That is the most ridiculous way ever that you can run a business like this. Our medics are well-trained. In fact, I would trust them with any of my lives, most of them. But no, but the truth is that they have gone to school a lot longer than some of our nurses have. And they know their skills. They could easily discharge at the scene. And what's really neat, if you've heard about it, is our community paramedicine model. That doesn't get reimbursed, but you know, you're doing really good. I've been on scenes myself. You know what, you're doing great. We don't have to take you to the ER today, but you know what? I'll come back in 4 hours and see you and see how you're doing. But if anything happens in there, I'll come back sooner. Why don't we have those kind of systems? They have them in Alaska. They have them in Europe. You have some really talented people and definitely good medical direction. We should do that in Minnesota. So that's a great question, John. Thank you.
To fix that reimbursement about needing, if you discharge at the scene, that would have to be a federal fix, or that could also be?
Because here's the other problem in Minnesota, we have an aging population. 80%, if you don't think government's in your life in this area, it is, because 80% of our payers are government payers, and that's about 80% of our patients. And I'm gonna say what I said in the task force, nowhere else does somebody bill you $1 and get back 22 cents. And I don't want to go after our food program, but if the grocer turns in their coupon to get reimbursed by the federal government for $1, they get $1 back. Healthcare, we maybe get 20 cents. In a good day, we might get 40 in Medicare. It needs to be fixed, and Washington knows it.
And just one comment.
EMS, an essential service, and so what's the funding source?
And we'll take that, but one thing on the billing, in greater Minnesota, like ambulances, like in Tower, Browns Valley, Graceville, stuff like that, 80% of our runs are a public option. So we are getting paid 20 to 30 cents on a dollar. The question over to here about a short-term funding, the challenge that we're seeing, I would relate this to like the nursing homes last year that we had. So we won't know what the February forecast is, but I would challenge the leaders, both in the majority and the minority, that if we definitely see a forecast that's coming back greater than what we thought, we need that $120 million. For the simple reason is, again, we are in a situation like the nursing homes last year. We have services in the area, if you guys are in that particular call area, that is challenged and getting the rigs out of the garage. So just addition to that.
Essential services, that's a great question. And every one of my colleagues have asked me the same thing. Why aren't we essential? It goes back to the Constitution, right? Read that first couple lines of the Constitution. It says the state has an obligation to provide the safety of the public, I believe. I should know it better, sorry. But it's right there. And so there's always a discrepancy if even fire's in that need. We do have to relook at that as legislators to say what this comes into, and I've had this discussion with many legislators in leadership. I say, well, it's not an essential service, but it is a value. And, you know, neither is higher ed an essential service, but boy, we really fund that well. And so I think that this is one of those things we got to tear apart. And like Representative Backer said, I mean, he lives this every day. I'm retired now. And that's the thing, is he's out there, and it's a mess right now. And we have to, I don't want to say it's broken, because you know what? These people behind me, it's not broken. They will do their job. They'll give up birthdays. They'll give up weddings. They give up everything because they're going to keep it from breaking. What we need to do is make sure they don't break. And that's what this is about. This is about making sure we keep them, and that they keep saying, you know, son or daughter, you should get involved in EMS. That's not happening right now.
How far does $120 million go? I mean, is this something that we're going to need to return to next year to make a meaningful impact? Obviously, you know, a long-term solution is something that is on the table later, but I mean, with the impending, you know, structural imbalance.
That's a great question. And to be honest with you, that number came from the league. And I'm sure they did their research on it. It's now a bill that Representative Lislegard carried in the House, and Representative Hauschild is carrying it, Senator Hauschild is carrying in the Senate. And so it'll go into our fiscal, and how we look at it as a legislature. If I said that right? And so that'll be a question for down the line of where does it go, how long will it last? It's really I think it's a drop in the bucket. If I just do simple math, no mathematician, that might be a good number to look at every year. And ongoing, we can't use surpluses for something like this. This is not a surplus. This is a service we all need, all use. EMS has more calls than fire do in the state, but yet half the revenue goes there. And so we need to really look at what is a sustainable funding model for this, and where do we find that money? And so that's what, if you remember the task force last week, that was the assignment to all members. Start looking at where we can find this money, because it's really important. And we don't want to wait till somebody has an unfortunate situation here. We want to do it now, so we can be there at that unfortunate time.
But is that, I mean, does that inevitably look at a proposal, would one of you bring that forward of a tax increase, like a local tax increase somewhere? I mean,
And on my
you
last
saw-
term, I'll bring that forward. No, it's, well, and that is the,
Sustainable
right.
funding for transportation this way, I mean, we're looking at a structural imbalance, at least according to the last forecast. How are you gonna get the extra money otherwise?
And that's a great question, and we are gonna have hard conversations. Because it goes with the Minnesota values. Where are we? And this is not, and it was so interesting because I have great EMS in my area. I have great response times. This doesn't happen in Rosemount, Apple Valley. Where it happens is in Representative Lislegard's area, where they gotta look for an ambulance service because maybe one's taking a mental health patient to North Dakota. And basically, the response times get screwed up. This is in our rural Minnesota that we gotta take care of first. So maybe it's a stepping on how we fund this. Maybe it has to be stepped up. At the same time, the individuals behind me from the House and the Senate, we're looking at making a rush on Washington this session. We're gonna go out and talk to our legislative leaders in Washington and have a long talk with them about this. I think now is the time, because we're not seeing any national trends, but Minnesota can really lead this. As the doctor said, we're ahead of many areas here. We were some of the first in EMS. In fact, I can brag about doing the first ECMO transport, but we'll talk about that another time. But no, we are the first in Minnesota to do a lot of things. We have to maybe be the first so the country leads us. Like I said, Alaska's doing a similar model change right now. Idaho, Jeff, you've researched a few of these areas?
Yeah, Wyoming,
Yeah, and so it's
Ohio.
It's rural areas across the country are having the same problem. Where the population decreases, we're starting to see the money not getting there, and that makes sense. But here's the deal: I can go down 3 feet either side of my house, three houses down. They own cabins. You know where they own cabins? Up north. And I want them to be safe, because Minnesotans like to water ski. They like to do fishing. They like to do all sorts of things all over this state. We want to make sure if you do that, that you are going to have coverage.
Can I just say something in this regard? So in the EMS task force, we got a report from the EMSRB talking about the revenue and the costs for EMS across the entire state. What that found is that the actual revenues to cost are in the green if you look across the entire state. Now, where do you suspect, based on what you've heard, the red is? It's in mostly greater Minnesota. And so when we're talking about this issue, I just want to be clear that overall, there are some folks making money on EMS services. And so there's an opportunity for us to look statewide at this issue. I will just say, in a lot of my rural communities who are just doing their best to provide BLS service, they're asking me to look at a regional tax authority for this issue. And I look at them and I want to give them that opportunity, but it makes me sad because I know at the state level, it's net green. It's inequitable, it's unfair, and it's a rural issue. So that is what I'm trying to elevate. There are people making money on this, and there are rural communities starving and asking to tax themselves more on this issue. It's absolutely absurd, and we've got to figure out mid to long-term solutions on this issue.
And the truth is go back to the senator's comment on the taxing districts, because yeah, these people come forward and they're willing to go ahead and put that tax out there. Try it for schools. I'm glad I have the education background. They cannot get a referendum passed on schools. That's why we had to go to school level equalization. I don't know if taxing districts are the answer, because they also, again, where's population decreasing? You know, if you don't have a taxing base, you're not gonna get that revenue. We gotta, and if you guys have ideas, I'm open for it. So, somebody else had a question.
You referenced just a minute ago in terms of transporting someone to North Dakota, and I think some other speakers nodded to it, but can you talk about how is the closure of rural hospitals making this work, like creating even more pressure and issues here? Because longer transports, or people might
You know
not be
what,
able to get to
somebody
the
that
hospital
actually knows,
themselves.
somebody
but-
that's been there right now
Yeah,
currently, I
yeah.
think should talk to that, yeah. I mean,
So healthcare is changing, and we're seeing that continuous move to see how the hospitals and clinics are functioning is different than it was years ago. So we're seeing a lot of need for people to go to specialty centers. Those are kind of popping up in different areas. In order to get patients there, they have to find, there's transportation needs to move them. On top of that, there is some hospital and clinic closures, but even above that, we're just seeing more and more people coming in who need care in general, and the hospitals just don't have room anymore. So even if you went into I live in Albert Lea, Minnesota. If you go into the Albert Lea Hospital today, they had to close the hospital years ago because it just wasn't a fundable model, as we're told. So we now have to take a patient from that emergency room to another city. But even when the hospital was there, that hospital filled. And so that meant we had to look for other beds, and you'd start calling hospital to hospital to hospital. They were all full, and we were starting to transport further and further. Behavioral health is even a larger issue in that same topic. So when we talk about behavioral health patients, they're being boarded in emergency rooms for days, sometimes weeks, waiting for some bed to open up at a facility somewhere. And although the emergency rooms do a good job of overseeing them while they're there, they don't have the capability or the specialty to do to provide the actual mental health care that they truly need, and they just sit and wait for a place to go. So, on top of increased 911 calls, an aging population that has more health needs, there's just the brick and mortar build that we've had in the past is not sustainable. We have to move patients more and more often, and that falls back on the ambulance services.
Care model that Senator Seeberger talked about last week fit into all this?
Yeah, it can.
we have a couple people that can talk about that. Go
Yeah,
ahead.
and my background is actually I am a community paramedic here in Minnesota as well, and that has been talked about within the sprint car model. So in rural areas where they're having a hard time finding volunteers to assist, to provide ambulance care for the day, one of the ideas that's out there is, could we send a paramedic or a community paramedic from another agency or another service area to go out into that community, be in a response vehicle, and be the second person for that ambulance for the day? And then that allows for, in places where they've traditionally had BLS care, it opens up opportunities for ALS or advanced level care to come into those communities. If we do find ways to involve community paramedics or community EMTs into that model, there's the ability for some increased health care to be provided to others in the community outside of the emergent 911 response, and kind of make maybe more use out of a full-time team member where maybe a volunteer was previously. So it's not an ultimate solution to all of the problem, but it's another option that could come into the industry to help solve some solutions in some areas.
And what we're seeing in Alaska with that model is more of an actual medic that runs almost like a state patrol model. They're actually on patrol. And they go throughout these, what we would consider our primary service areas, and they basically are the first responder as a paramedic into that situation. And remember, transport is a treatment. It's not the only thing that we do. We do tons of they do tons of others. I quit including myself in the pool. But they do a lot of things, and they can do more. And with telemedicine and innovation, we're looking at every way possible that we can do the right thing here. I got a guy looking at the time that used to work for a governor, so I mean, we all know what this means.
I have one clarifying question on the Seeberger model. When she described it, she said it was, kind of a way to, if you're only getting paid for transporting somebody in an ambulance, to not have that ambulance come all the way out there for somebody who might not need to go to a hospital in an ambulance. So my question is, if a paramedic is coming out in this sprint model, are they being reimbursed at a rate that, because you're doing it to try to save the ambulance from coming out unless it's necessary. and not have have them have a sunk cost for nothing. But are paramedics, that service reimbursed in a way that it makes financial sense to do it this way?
Absolutely not.
Okay.
So that's what the problem is that this is where the state plays a role, right? This is where we look at, how do we fund a model like that, or how do we fund a BLS service that's failing? These are the questions we have to do, because if we get the no, there's a bill in Washington right now for Medicare reimbursement that is treatment non-transport, that would fit this model. So what we want to do is get data to Washington saying, here's our outcomes. We have a surgeon right now, a local trauma surgeon, that's doing a study that's already telling us that interventions by an ALS care provider at the scene have definite impact on outcomes and expense down the line. And so we're looking at the best practices that are out there right now, and that's kind of how, and these people behind me are gonna have say in this. They're the ones on the street to say, I don't think that model will work, and that's who's gonna make the decision for us. We're just the policy writers. And so they're gonna be engaged with this. They're gonna tell us what their eyes and ears are on the scenes. They're gonna tell us if this will work or not. And we're looking at working with them to get this done. But this is where the state's gonna have to look for more permanent funding. Good question, though.
Thank you all. Thanks.
Thanks, guys.